much, Henning. We'll move on now to, thank you, Shahrad Taheri, who's going to talk to us about diabetes remission and then highlight some of the research needs and issues relating to translation into practice. Shahrad, thank you.
Well, thank you, Tony. The next slide, please. Well, thank you, Tony, and the organizers for inviting me to speak with you today. And I'm delighted that you've had some great presentations, particularly Michaeline has set the background for my talk, which will be helpful in moving forward. Next slide, please. These are my declaration of interests. Next slide, please. So I'm going to talk about the problem of obesity and type 2 diabetes, particularly in the region that I work in the Middle East and North Africa, and then talk about our ideas about the natural history of diabetes remission. So I'm going to talk about two studies based on two hypotheses, one carried out in the UK together with colleagues at Imperial College, and another one carried out in Qatar. So Diadem 2 and Diadem 1. And Diadem 2 actually was conducted way before Diadem 1. It's a little bit like Star Wars films. So we did the later films before the early films. So it'll be interesting to see how the thought patterns develop from that. And then talk about some exploratory data regarding factors related to diabetes remission amongst the Diadem 1 cohort. And then finally end with research needs and translation. Next slide, please. So here is the Middle East region, Eastern Mediterranean region, based on data from the International Diabetes Federation. As you can see over the years, it's going from 1980 to 2014, the prevalence of diabetes has really increased in the region, and the region is having a surge of diabetes that will continue moving forward. Next slide, please. And this points out that actually quite a significant percentage of deaths in the region is occurring in people who are age 60 or less from diabetes-related deaths. So many younger people are affected in the region with diabetes, and many of them end up having diabetes complications. Next, please. And the cost is obviously great. So this is looking at 2017. You're going for $20.5 billion US dollars a year to $37.1 billion a year across the region. And this is going to increase even further with the complication of obesity and diabetes, people requiring dialysis and treatments for their diabetes complications. Next slide, please. Here's a region where I am, the Persian Gulf region. You can see the prevalence of obesity is fairly high. So in Qatar here, we've got 72.2% who've got issues with overweight, and about 34% of adults who've got issues with obesity. And it's all reflected across all the countries in the region. Next slide, please. So here's Qatar. It's a peninsula within the Persian Gulf. It's got a population of about 300,000 local inhabitants, and a total of 3 million. The remainder coming from other areas of the world to come here to work. The country is very rich in gas, natural gas, and that has generated development in the country. You can see the extensive development that's occurring in Qatar. And part of that development has been the nutrition transition that's taken the country from traditional foods to additional Western lifestyles and behaviors and additional Western foods that have resulted in the surge in obesity. The good thing about Qatar in terms of research is that because it's such a cosmopolitan, multi-racial community, any study that we do in Qatar has got the benefit of showing greater generalizability across different populations, and you will see that when we present the data. Next slide, please. So Qatar ranks 10th in the world for diabetes. About 1 in 5 have got diabetes, and impaired glucose tolerance is also fairly high, about 1 in 5, 17.1%. What's remarkable is that 2/3 of the patients with type 2 diabetes in Qatar are young and are aged less than 50 years old. So it's a specific population that requires attention early on. Next slide, please. So this is the life of a diabetic. So you start with some tablet for diabetes, and then tablet for cholesterol and blood pressure. As years go by, you accumulate tablets and then injections, then finally on insulin and multi-dose insulin regimens. So quality of life for somebody with diabetes is going in a negative direction. You can see the picture in a way that determines what burden people carry with diabetes in terms of their disease. And the view has always been that actually it's a lifelong disease. There's not much we can do. We can give them a little bit of diet and activity advice, but most of our goal is to give them treatment through medications and then treat their complications. But a question we need to ask is type of diabetes really permanently lifelong, and does it need to be treated with medications lifelong? Next slide, please. So I'm going to talk about two hypotheses that we had. So I'm going to start with hypothesis 2, actually. And our hypothesis 2 was based on this burden of insulin in patients with diabetes. And the question was, what if we take people who are in advanced stage of diabetes or on insulin with reduced quality of life, and can we actually improve their quality of life by getting rid of insulin or reducing their insulin dosage? And this second hypothesis, actually our hypothesis 1, it took a longer time to implement, was that if we take people with early diabetes, can we actually reverse it? Next slide, please. So we had to learn some lessons from bariatric surgery, because bariatric surgery took on the mantle of diabetes remission and achievement of sustained, maintained weight loss. So weight loss, first of all, is a key component of diabetes improvement in bariatric surgery. There are, of course, different mechanisms, but weight loss is the key. And weight loss in bariatric surgery is usually rapid and occurs in the first 3 to 6 months, after which there's a weight loss maintenance phase. And the factors that are related to diabetes remission are younger age, early disease, better control, fewer medication, not taking insulin. So our target group has to be somebody for remission if we're going to look at younger age and early disease and rapid weight loss. Next slide, please. But weight loss does occur from all interventions shown, but the problem is going to be weight maintenance. And this is the strength of bariatric surgery, is that it's demonstrated good weight maintenance, although there is some weight regain over the years. Next slide, please. You can see this systematic review shows that those who use meal replacements and who lose weight rapidly, as you can see here within this short time frame, tend to keep the weight off better. So a weight maintenance approach that uses meal replacements early on could be the beneficial effect that we're seeing. So that's one of the reasons that we chose meal replacements in our studies. Next slide, please. So how do we achieve this weight loss maintenance? We also learned from the DPP and look ahead. So those who attend appointments, which meant that we needed greater number of consultations, greater attention paid to the patients, more patient contact, adhere to calorie restriction, meal replacement, again important. So we had to build that in, increasing physical activity. As you all know, when people lose weight, their energy expenditure goes down. And this energy expenditure needs to be made up by physical activity. And again, if you look at the Swedish Review study, the difference in weight maintenance between the control group and the ones who received surgery was about 200 or 300 calories. And that can be made up with physical activity. And again, early weight loss was the key. So in look ahead, those who achieved good weight loss in the first year were able to maintain it at 4 years. Next slide, please. So let's start with hypothesis 2. Can we take people who are advanced diabetes? Again, we weren't talking about diabetes remission. Can we take them and actually see whether we can reduce their insulin burden? So this study was carried out by Adrian Brown, and when I designed it, the idea was to reduce the patient burden. So they're older patients, as you can see, they tend to be mainly white. The HbA1c is not so well controlled. And you can see that the duration of diabetes is about 12 to 13 years. Next slide, please. So you can see very nicely here, this is the top, in terms of weight loss, you can see the top curve is basically great dietetic care. And with great dietetic care, it's possible to achieve and maintain reasonable weight loss. But by having a total diet replacement phase in the first 3 months with gradual meal introduction, it's possible to achieve greater weight loss. But as you can see, at 6 months, when the contact frequency goes down, there's this element of weight regain. So we need to learn from that and ensure that there's this greater contact that allows better maintenance of the weight. You can see that the HbA1c improved greatly. Again, greater improvement in the intervention group at 12 months, although this was not significant. But what is key here is these people are taking less insulin. And you can see that in this figure here. You can see the insulin dosage starting from a level of about 70 units a day. You're getting fairly big reduction in insulin. And about 40% of those in the intention to treat analysis achieved of completers achieved reduction in insulin enough to get rid of insulin completely. Of course, this was associated with greater quality of life. So we achieved through this, I think it's a very important study, with people with advanced diabetes on insulin, it is possible to take away insulin in a significant group. This kind of dietary approach can be given to people who've got even advanced diabetes. Next slide, please. So moving on to diadem 1. So diadem 1 now wants to do reversal of diabetes. Can we achieve diabetes remission? So to do that, we need to learn from bariatric surgery. So we went with people who were adults between 18 to 50 years old, who had early type 2 diabetes, less than or equal 3 years. They were recruited from primary care, and the intervention occurred in primary care and a community setting. And the intensive lifestyle intervention, and the reason we called it a lifestyle intervention, because it wasn't just a diet, it did really include behavior change. Really, we had a curriculum that really supported the behavior change, and also there was unsupervised physical activity support. So our new philosophy was take younger people, get them to lose a lot of weight early on, maintain it with physical activity if we can, and see whether we can achieve good weight loss and diabetes remission. Next slide, please. So we recruited, the BMI cut point was 27 and above. So we used meal replacement products. There was a total meal replacement phase. I'll go through that in a minute. Then we introduced food gradually, build up the physical activity, and had a multidisciplinary team support. Next slide, please. So you can see the stages here. So in the first 12 weeks, they had total meal replacement. They saw a dietitian and a trainer every 2 weeks. They saw a physician in the beginning. So we stopped all the diabetes medications in the beginning and reduced or stopped their antihypertensives or cholesterol medications based on clinical judgment. As you can see, then there was a follow-up with lifestyle change up to 12 months, and I'm going to present to you the 12 months data. Next slide, please. So just to show you what our cohort looked like. Firstly, if you look at we've broken them into North Africa and Middle East participants. You can see they came from 13 different countries. So this shows really generalizability of the findings across multiple groupings. There were 147 participants. The majority were male, which is unusual for most of the studies carried out in European countries, which are mainly female. And this reflects actually the population of early type 2 diabetes in primary care in Qatar. About 10% were managed by diet alone. And you can see that quite a significant numbers, nearly 70% were on 3 or more medications. One area that we need to point out is because this is such an intensive intervention, people have to come regularly, and they're younger individuals, so they're in employment. So 85% are in the working age group and are working. So it was possible for them to turn up and actually achieve the intervention. Next slide, please. In terms of complications, you can see having early diabetes, there are very few complications here. In fact, there was only one case who had a previous history of myocardial infarction. About a third had high blood pressure. Interestingly, nearly half reported snoring, although only 4% had a diagnosis of sleep apnea. And gastroesophageal reflux disease was common as well. Gout was not a contraindication in our study unless it was active. So about 10% had gout that wasn't active, and they entered the study. Next slide. So in terms of body weight, you can see this is the control group. And the objective of the control group was to provide them with advice as well as support in terms of medication that optimize their weight loss. So what we provide them with the GLP-1 analogs, with the SGLT2 inhibitors, optimize the metformin, got rid of medication that might increase their weight like sulfonylureas. And you can see they achieved fairly modest weight loss, and it's equivalent to all the trials of GLP-1 analogs in terms of weight loss in diabetes. However, the intervention group achieved substantial weight loss, most of it occurring in the first 3 months, a little bit more 6 months, and they maintained it across 12 months. Next slide, please. You can see most of the weight loss was from fat mass in the intervention group. So generally this is based on bioimpedance, so we didn't carry out DEXA scans, but what our data showed that actually muscle mass was preserved, which could be because of increasing physical activity that was incorporated into the study. Next slide, please. So in terms of achieving milestones of weight loss, you can see a fairly significant percentage, 60% achieved 5%, and a third of the control group also achieved that because we were optimizing the medications. However, when you go to greater degrees of weight loss, 10% or more, or 15% or more, you can see that intervention, about 1 in 5 achieved greater than 15% weight loss. Next slide, please. HbA1c improved, obviously, in the control group because we were optimizing the medication. They achieved modest weight loss. However, you can see that the degree of improvement is not only greater in the intervention group, but also is sustained, and also these individuals are not taking medications, the majority. So without medication, they've achieved substantially better HbA1c. Next slide, please. Now, for the headline here, in terms of diabetes remission, we define diabetes remission as an HbA1c of less than 6.5% and off medication for 3 months. But note that these individuals, the medication was stopped right from the get-go, which means that actually this is like they've been off medication for 12 months. This has been randomized. So this fits with a similar criteria as to the ADA consensus criteria in terms of diabetes remission. So in the intervention group, 61% achieved remission, which is greater than the direct study, and we can discuss why that might be. And this was 12% in the control group. However, you can see that 33%, 1 in 3, achieved normal glycemia. That is an HbA1c of less than 5.7%, which is really excellent. So we took these individuals with early diabetes and managed to put them into remission in the substantial group, and also a third of them into normal glycemia. Next slide, please. And in terms of insulin sensitivity, we looked at that in terms of quickie, quantitative insulin check index, and HOMO-IR, and beta cell secretion is HOMO-B percent B. You can see HOMO-B is actually changes, so there's a difference that's occurring between the two groups, of greater insulin sensitivity in the intervention group. Next slide, please. Now, we carried out 24-hour continuous glucose monitoring, blinded. As you can see, as you go over time, of course, every day, you can see how within 3 months, the intensive lifestyle intervention has got fairly flat glucose variability. The glucose variability has gone down, the HbA1c is improved, and glycemic control is so much better. And we were actually really shocked to see this happening so remarkably, and to see such an effect. Next slide, please. In terms of blood pressure, at 12 months, the intensive lifestyle intervention compared to the control group, 71% achieved normal blood pressure, while only 50% of the best medical group achieved that. Next slide, please. Now, how is our study different from other studies? Let's look at this a little bit in more detail. So we have direct here with the intervention control. We got the early active study where they took very early diabetes and they put them into diet alone, diet and physical activity, advice with a dietitian. The look ahead study and the scale diabetes trial using liraglutide, 3 milligrams. First of all, note that 73% are men in a study, which is much higher than other studies, and they tend to be younger. And this really is a reflection of what's happening in Qatar. You can see they're almost a decade younger in direct, and compared to early acted, but as early diagnosis of diabetes, you can see it's nearly 20 years younger. So diabetes are really occurring in the region at such a young age. I know that we were choosing them specifically, but it's a reflective of the population here. Much younger age of diabetes than other countries. There were 100% from the MENA region, whereas all the other studies are in white Europeans. The BMI and waist circumference are very similar. Diabetes duration is 1.8 years, which is less than direct, but greater than early active, because early active picked very early diabetes off primary care. And you can see the HbA1c is better than direct because the early diabetes, but worse than early active because it's a little bit later. And of course, better than the look ahead and scale diabetes. Next slide, please. And this shows it graphically in terms of age. You can see the group is much younger and the HbA1c is sitting a little bit above early active, but less than direct and less than look ahead and scale diabetes. Next slide, please. So the question we wanted to ask here is, what is it about who are the responders in terms of those people who lost weight within the intensive lifestyle intervention, who achieved remission, and those who didn't achieve remission? What's different from them? So you can see there's no gender difference, there's no difference in marital status, age. However, diabetes duration is interesting because it shows that those who responded had a shorter diabetes duration. So it could be that they're at an earlier stage of disease. The other area to look at is snoring. Interestingly, greater snoring was related to, was higher snoring in the non-responders. And interestingly, sulfonylurea was higher in the non-responders compared to the intervention group. Next slide, please. In terms of glycemic control, those who had better HbA1c, better glycemic control early on, were more likely to go into remission. As you can see, it's highly significant at baseline and also at 12 months. Additionally, the other factors that came across was fasting glucose and also high uric acid at baseline, but this was not significant at 12 months. So those ones who have shorter duration diabetes, have got better diabetes control, are more likely to respond to the intervention in terms of diabetes remission. And I have to say that these two groups both achieve similar weight loss. There's not weight loss between these two groups. Obviously, weight loss is a major driver of remission, but between these two groups, they both lost weight, but the responders had worse control to begin with. The responders had better control to begin with compared to non-responders. Next slide, please. Now, we had the usual adverse events that you would observe in a clinical trial using meal replacements and changing diet. So we had the constipation, the dizziness, the cold intolerance, and the hair loss. But I wanted to point out, because we were talking about COVID here and increased risk of infection, one of the things that we notice here, if you look at common cold here, is much more frequent in the intervention group. This is in phase 1 where they were losing a lot of weight, and again also in phase 3 where they were going to meal introduction. Now this could mean two things. Either the immune function has changed in such a way that actually it's waking up, actually it's more reactive to infections, and that's why people are reporting more infection, or it could be that actually there's an effect on the immune system with the intervention and the weight loss that actually makes people more susceptible to upper respiratory tract infection. But we don't really know the answer. Of course, it could be because we see these individuals more often during the early phase because they're seen every 2 weeks compared to the control group. But that does not explain what's happening at phase 3 here and why they're reporting greater number of common colds, because at this stage they're being seen almost the same frequency as the control group. So the jury's out as to what impact this is having in terms of immune function. Next slide, please. So how do we translate this into practice? We've started our diabetes reversal clinics, and it started at the National Obesity Treatment Center in Doha in Qatar. So, and this is going to expand across Qatar. And Qatar is very lucky because there are these wellness centers within primary care. So these wellness centers have got physicians who can give physical activity on prescription advice. There's a swimming pool, there's a gym. So it's really possible to actually provide the physical activity and physical activity support directly rather than just give people advice like we did in DIADEM 1. And also what's occurring in Qatar is there's going to be a national screening program for adults to screen people with diabetes. And once we screen this individual, the earlier we intervene, we can get them straight into a diabetes reversal study and prevention study. Next, please. So the research needs are when do we intervene, and based on our observations compared to direct, achieving better remission, but also looking at the literature, the earlier we intervene, we're going to get better outcomes. And we need to really think about, because screening has got such a bad press based on previous data, because the screening was carried out and then the intervention that followed it was usually medication. But can we link our screening with diet and changing lifestyle and getting people into having a better quality of life long term? Are there other dietary approaches that we might use? So we need to look at that. So we just use one particular type of meal replacement, the same as direct. We'll supervise physical activity help. And this is again, will that help maintenance and how we manage maintenance through more frequent contact, whether this is done remotely through using the internet or mobile apps, etc. Next slide, please. So to conclude, diabetes remission is now a reality. It's been shown in the UK now, and it's been shown in Qatar, in the Middle East and North Africa. So we need to really put that into our armamentarium of treating patients with diabetes. We need to rethink type 2 diabetes care and reduce reliance to medication and put remission as our first priority, because this has a significant impact on quality of life for people, and aim to reverse as early as possible. Next slide, please. So I want to thank the DIADEM 1 team, colleagues at Weill Cornell Medicine in Qatar and New York, and Cornell University in New York. Hamad Medical Corporation is the main medical corporation here, together with Primary Healthcare Corporation. So colleagues helped Qatar Diabetes Association. So these are the team who contributed to that. Adrian Brown and Gary Frost for our DIADEM 2 study. Funding was from QNRF and Qatar Foundation. I put this picture especially here. You can see the skeleton here, because when I first started this study, I never thought it would happen, because we talk about direct being the first published study, but actually this study was designed in 2012 and funded in 2013. And it took us a long time to set this up, because we were doing the first major clinical trial of lifestyle in the whole region. We were setting up clinical trial infrastructure in Qatar. We set up the first data and safety monitoring board in Qatar. So I'm glad that I didn't end up being this skeleton now, so I can report the data to you. But actually, the skeleton is a team who worked really hard to make it happen. So thank you for listening.
Thank you very much. That was a splendid summary and raises some interesting questions. You referred to physical activity, which in the majority of clinical trials, it's quite difficult to get people to do what we would like them to do. There's also the question of monitoring so that we know exactly what they do. You did monitor physical activity in the DIADEM trial, didn't you? What do you have any comments on the practicalities of doing this and making changes?
Yeah, I mean, yes, we did. So we did monitor them. So we're analyzing the data at the moment. But what's really interesting is these individuals are actually quite active already from baseline. So because most of them were working and most of them doing jobs that required moving around. So they were quite active to begin with. So we didn't see a huge change in physical activity. I think we need to think about how we assess physical activity. I don't think actigraphy is really good enough. So in future studies, we need to look at fitness and look at ability of fitness more than actually measuring activity through accelerometry. But using from the questionnaire basis, we used the International Physical Activity Questionnaire, which we reported, and the outcome showed that they were reporting being more active. But generally, we find that because they're young, they were fairly active anyway. And you don't really need to be, like I said, you only need 200 to 300 calories difference. You don't need to be hitting the gym to be able to achieve that.
Mike, do you want to make a comment or a question? Turn your microphone on, unmute your mic, please. Yes, I can hear you now. Yes.
You've turned me on, thank you. Yeah, I agree entirely with what Shahrad was saying about physical activity. In DIRECT, we measured physical activity using accelerometers, and essentially we found that despite encouragement to increase physical activity after losing weight, they didn't do it. You've heard from Denmark that really the same thing happened there. And efforts to increase physical activity have been very, very unsuccessful. We simply haven't been able to do it. The Look Ahead trial similarly found basically no reduction in cardiovascular risks through their physical activity program, although of course there was from 10 kilograms weight loss in Look Ahead. So we're not good at helping people, encouraging people to become more active. And I think perhaps we should recognize where our strengths lie until we have a better way of doing that, and focus very strongly on the weight loss. And that is the big one. I think if people can lose the weight, they're going to get shot of their diabetes. They'll no longer be diabetic. They will lose their risk factors, even if they're not becoming more physically active.
Thank you. A comment then, it's not clear who it's from, but the population in Qatar tends to be transient, with people coming to work for a few years. Is that going to present you with a problem in terms of doing very long-term follow-up and long-term outcomes?
I mean, this is one of the reasons that we're actually worried about doing long-term trials here. And in fact, we were lucky that we have such a great retention in our population, which was fantastic. But now, as the program goes into the general population, then we're going to have more of the indigenous population benefiting from that. But we were really lucky actually that, we're always worried about people going away for holidays, and there are also lots of challenges within the Middle East, like the Ramadan and Eids, and people having buffets and all kinds of things. And people in the study actually managed to overcome all that, which was really surprising to all of us, that actually they got it and they managed to control things despite having lots of temptations.
There's a question from Michael Livingston in Adelaide in Australia. Do we have a broad view on economic advantages of use of programs that start with the TDR over alternatives? And I know health economic analyses have been done. Mike, do you want to comment on that?
Yeah, we've now published 3 papers on the economic analyses around DIRECT. They are very specifically in the setting of the National Health Services, plural, in the United, supposedly, Kingdom. They're very different, but the principles of diabetes care are essentially the same within Scotland and within England under different national health services. And what we've found there is the most recent analysis was a long-term cost effectiveness over a lifetime projection. There is an upfront cost of establishing a service and putting patients through a weight management program, but that is immediately offset by reduced costs of drug prescriptions and reduced costs of hospital visits and referrals for a multitude of things, including minor infections. I was interested that Shahrad has found more minor infections in his intervention group. We actually found less, and there were less referrals to hospital. So there are economic advantages accruing. And the projection was very precise, and they have indicated that the cost of the intervention would be recouped within 5 years from the beginning, and that over a lifetime, the total healthcare costs of people who go through this intervention will be less than those who do not go through it under current NHS guidelines. So there's a huge advantage, and in fact, one can make really no argument for not providing a remission service, other than the fact that you do need to have a decision made which will divert funding for a short time towards setting up the service. And that probably applies in almost any funding arrangement, even with private healthcare. Individuals in countries where there's private medicine will be spending a lot of money themselves out of their pockets for their diabetes and getting a great deal of pathology at the end. If they can get remissions, they're going to spend less money and have less complications.
Thank you very much. Shahrad, do you want to just make a comment?
We're in the process of doing some health economics, but one area that people don't normally look at and what we observed was actually the family was getting slimmer, and family was losing weight and becoming healthier as well. So that has repercussions for in terms of costs as well. So it has a wider effect than just the individuals who is affected with diabetes.
Yeah. Okay, could we just briefly, and I'm watching the time, we've had such an interesting morning with lots of good questions that we're getting close to the closure time, but in the last few minutes, could I just ask, do we have any information about other inflammatory arthritis problems, Henning? Any other trials in any other areas, such as gout?
Well, as you may know, we have conducted a trial, not yet published, with gout, and I can say that the results are so positive that it should be definitely implemented worldwide. But we are struggling with the final statistics. But people with gout can lose weight, get better. Their uric acid decreases. They don't get gouty attacks as we would have expected with the major weight loss. But exactly the same program as I showed you for the knee participants has been conducted with gout with very, very positive results.
Yeah, thank you. There is a question from earlier on in the day, which was addressed to Mike. What is the position with regard to using partial meal replacements? In other words, is there scope for using a mixed conventional meal and 1 or 2 meal replacements per day?
Well, I mean, I would have to agree with Henrik and with Shahrad on this score, that if you give people the option of chopping and changing, and the element of choice comes in, then there's an immediate opportunity for slippage. And I think our patients, we have detailed qualitative analyses of this as well. Our patients found the discipline being restricted for a short period, and well, short is 12 weeks short. I don't know, it was regarded as acceptable. That the discipline of saying, no, I'm not going to a restaurant, I'm not eating with my family, I'm not eating, I'm not having a nice latte in a restaurant with my friends. I'm going to take this very seriously, as you would the treatment for a cancer. We're going to take this seriously. You're going to hope for a remission in 3 months and take it very seriously. And that discipline rang a bell, and they were able to adhere to it. And the minute you start offering, oh, well, you can have 2 meal replacements and something different for your evening meal, which has been proposed in other areas, that does introduce slippage, and the patients tend to do less well.
Yeah.
Have some experience in managing relapses, so patients who start to regain weight. And one of the things we did in Direct was to offer them a short course of total diet replacement, or the use of meal replacements at that stage. And the ones who had the total meal replacement are actually attended. I think as much as anything, it was the actually return attending the clinic, which was the prompt, whereas those who used just meal replacements didn't do so well.
Yes. Okay. Well, thank you very much indeed. I'm afraid the time has run out. So thank you very much indeed for your participation. Splendid presentations. We've had a very good discussion. Thank you very much to the Secretariat as well, Felix and Andrea, for organizing this. Thank you to the over 100 delegates who participated and for sending their questions through to us. There will be recordings later on. Please can I encourage you to complete the evaluation forms. I'm sorry, Carol, we didn't have a question for you in the discussion, but it all worked very well, I think. I may have to be a little bit hesitant, but I have a feeling we may well organize a follow-up event sometime in the autumn. So we've had a great time. Thank you. You can go to the website and look for the recordings and the other files related to this meeting a little bit later on. Thank you. I wish you a very pleasant summer if you're in the Northern Hemisphere. I know there are people watching from the Southern Hemisphere. For them, I suppose it's a pleasant winter. I wish you well. Thank you very much for your participation.
Thank you.
Thank you. Bye-bye. Bye.
Cheerio.
Bye-bye.
Right.
Just press leave, Henning, in the bottom right-hand corner. Bottom right. Okay, just press that.